Good morning and welcome back to UCI Mind's monthly Facebook Live series, Ask the Doc, Alzheimer's Research Today. My name is Chelsea Cox. I am the Associate Director of Education at UCI Mind, which is one of 32 congressionally designated Alzheimer's disease research centers across the country, and the only center right here in Orange County. This series is your opportunity to ask questions of our experts at UCI Mind who are researching Alzheimer's disease and dementia and brain health. Today, I am very excited to be joined by Dr. Ahmad Sajjadi. Welcome, Dr. Sajjadi. And just to briefly introduce Dr. Sajjadi, he is an Assistant Professor of Neurology in the UCI School of Medicine, and he received his medical degree from Tehran University of Medical Sciences in Iran, as well as his PhD from Cambridge University in the UK. Dr. Sajjadi is a behavioral neurologist who sees patients clinically at UCI Health, and he also conducts research in Alzheimer's disease, as well as atypical forms of dementia, such as frontotemporal dementia. Dr. Sajjadi, thank you so much for joining me today.
My pleasure. Thank you.
I'm sure that our viewers are going to have a lot of questions on this topic of what causes memory problems in people as they age. So viewers, please, as questions come up, go ahead and type them there in the comments box, and Dr. Sajjadi and I will try to get to as many questions as we can. And please do remember that any questions or anything that you type in that box will be visible to other people who are viewing, as well as it'll also be linked to your name. Okay, so Dr. Sajjadi, to begin, is it true that everybody develops some type forms of memory or cognitive problems as they get older?
Thank you. That's a great question. I think I should take a step back and kind of mention or start by saying what the difference is between memory problem and cognitive problem, which is a kind of more general term. When we talk about cognition is a broad term, and it encompasses a number of the so-called cognitive domains. And memory is one of the cognitive domains that we recognize as part of our cognition. But there are other cognitive domains, such as language, such as visuospatial abilities, such as behavior, the way we kind of interact with our surroundings, such as what we call executive function, which I'm going to take some time to describe because it is an important one. So our executive function is our ability to conduct ourselves in a complex environment by breaking down any kind of complex stimuli or any complex task to its elements, and trying to basically execute the actions in as efficient way as possible to arrive at a desired conclusion. And executive function is what is commonly affected as we get older, because it has to do with our speed of processing of information, which, as we know, sometimes declines as we age, as a kind of process of aging, which can be a normal thing. And also in terms of our ability to kind of do multitasking, which is again something that we know people who, as they get older, become slightly troubled with. So a common scenario for us is to see people who are complaining of memory problems, but actually it kind of boils down to an issue with their executive function. So that is something that is expected with aging, the reduction in the speed of processing of information, and also the problem with multitasking. So that is something that we do see. And that kind of problem with executive function can sometimes be perceived as memory problem. For instance, if I'm talking to my friends and I'm kind of trying to remember the name of an acquaintance and that doesn't come back to me straight away, I kind of conclude in my head that I have a memory problem, which is actually not exactly correct, because that name will come back to me a bit later than what I wanted, but it will come back to me. So in that sense, it is a problem of retrieval or the speed of retrieval of information. So that is something that we see commonly with aging.
Okay, thank you. That is a great explanation. Now, what age would you say does this cognitive functioning start to decline in older people?
Well, that's another good question. I mean, it is kind of depressing to say that we are at our best when we are in our mid-20s and 30s, and after that, things kind of start going down. So in that sense, beyond the age of 30, kind of people might become aware of some slowing in their thinking processes, which is kind of what we have seen and studies have shown as something that happens. It should not or does not interfere with activities of daily living in any kind of meaningful way, but things sort of start to go south as early as 30s, basically, in terms of the speed of processing of information and multitasking abilities.
Okay. Now, when, Dr. Sajjadi, our memory changes not normal then?
Sure. So basically what you're implying by that is a degree of memory and cognitive problem is kind of expected, especially as we get older. And everybody has kind of experienced the tip of the tongue situation where when we are trying to provide name of people, as I just mentioned, and it doesn't come back to us straight away, talking about a movie that we had watched kind of the week before. I mean, the details do not come back to us straight away, and it sometimes takes a while. Sometimes we do things that kind of scare us, like putting things in places they do not belong and then not being able to find them later. So occasional lapses like that are happening in everybody. So in that sense, that should not concern us. The things that might be kind of early warning signs of something worrisome starting to happen is, first of all, if these things start to happen more frequently. So if someone starts having these issues on a frequent basis, noticed by others perhaps, and also the nature of the problem is important. So it is normal for somebody not to be able to remember the name of a friend or somebody who they do not see that often immediately, but it should come back to them. But if that kind of information does not come back to them, or people have no recollection of things that they are expected to remember, then that's the time that we should perhaps start getting concerned about the nature of these things.
Okay, so it sounds like paying attention to the frequency of when these lapses are happening.
Exactly. I think that would be the most important thing, as well as the nature of the problem.
Okay.
As well.
And so when someone is starting to notice those problems or those changes as they get older, how are memory and cognitive problems diagnosed?
Sure. I mean, I think, first of all, people, when we kind of live with people, perhaps not always we are aware of the degree or the extent of the problem, but our spouse or relatives or children might become aware of it. When sort of the degree or the frequency of these problems reach a certain limit, I would say, people start sort of wondering what they can do about it or whether these conditions are abnormal. And that's the time to see the primary care physician, as I think it would be a good starting point. Because, I mean, they can alleviate some of the concerns that are not kind of do not warrant kind of further follow-up, but also can refer the patients on to appropriate specialists who can look into these problems further. And in terms of what particular specialty, obviously, us neurologists, especially those who have some interest in cognitive and behavioral issues, are appropriate points of referral, as well as some old age psychiatrists in particular who have interest in looking after these conditions.
Okay. So a follow-up question to that, you recommended it might be good to start with a primary care physician. What type of tests or what would they do to?
Sure. So we have screening cognitive assessments that are available to primary care physicians. Obviously, before all of that, an appropriate history, especially one corroborated by somebody who knows the patient well, will be extremely helpful. Mm-hmm. But if at that point, I mean, there are enough concerns about what might be causing these cognitive issues, there are screening cognitive assessments that can be performed and administered at that point. And if the primary care physician is concerned enough, then they will follow the patient on after arranging for some basic laboratory assessments, for instance, to rule out certain deficiencies in thyroid function or certain vitamins that can cause the same kind of memory and cognitive problems.
Okay, so they might perform a brief cognitive screening as well as some blood tests maybe.
Exactly.
Okay. Yeah. And if they notice that there is something that's not normal for that person's age and education level, then and they refer to a specialist such as yourself, then what steps would you take to further evaluate the problem?
Sure. So, I mean, it's always, our kind of encounter with our patients always starts with history taking. So we always listen carefully to what the patients have to tell us and also what their caregiver has to tell us, because it is a common occurrence that the patients might not be aware or do not have insight to the degree of their problems, in which case a caregiver might be a better source of information in terms of the kind of problems the patient has been having. During that encounter, we try to kind of identify the nature of the problem in terms of its frequency as well as the kind of cognitive issues patients have. And then we will follow up by kind of physical examination. Part of that physical examination and part of the assessment will be more cognitive assessments that we will tailor make based on the presenting issue. And if basically the history and the physical examination and cognitive assessment are pointing towards a potential significant cognitive impairment problem, then the follow-up will be arranging for appropriate brain imaging. Normally we start with either a brain CT scan, which is a more crude way of getting information about the structure of the brain, and in patients who can tolerate an MRI, a magnetic resonance imaging, will be a better choice in terms of providing detailed information about the underlying brain structures that might be affected in certain cognitive impairment situations.
Okay.
And we might also want to arrange for what we call neuropsychological assessment, which is a more detailed memory and thinking test conducted by neuropsychologists who are experts in basically administering the appropriate kinds of cognitive assessments and also interpretation of the results of them. And if the sort of basic laboratory screening has not identified an issue, we might go on to, based on scenario, obviously, arrange for further lab work, looking for certain causes of cognitive impairment beyond this primary screening.
Okay. So all of these tests and imaging and things will help you hopefully arrive at a diagnosis of what's causing the memory and cognitive problems in people. One of the most common questions that I get when I'm out in the community is, what is dementia and how is it different from Alzheimer's disease? Could you speak to that?
That's an excellent and a very common question, absolutely. So I think it is kind of difficult and at the same time important to mention the difference between these two terms. I think I will start by saying that dementia is a state of abnormal cognition, progressive impairment in cognition due to a number of reasons. So dementia is a state of cognition or a state of abnormal cognition, which can be caused by a number of reasons. Alzheimer's disease is only one of the reasons that can cause dementia eventually. It is a particular disease in the sense that there are certain abnormal proteins that accumulate on the brains in people who suffer from this condition. So in that sense, dementia is a more general term, whereas Alzheimer's disease is a specific disease, but that's not the only difference. Another analogy will be, or an imperfect analogy will be that if we compare something like sepsis with something like pneumonia. So sepsis is the state of having an infection that has caused sort of impairments in the functions of our body. Pneumonia is a specific kind of infection affecting the lung tissue. And not all pneumonia will lead to sepsis. Not all sepsis is due to pneumonia. The same situation applies to dementia versus Alzheimer's disease. Not all dementia is due to Alzheimer's disease, and not all cases of Alzheimer's disease actually go on to develop dementia. Because we, as reviewers might be aware, that Alzheimer's disease comes in a spectrum. So it starts with normal cognition. Of Alzheimer's disease, actually, people have normal cognition and they are not even aware of it. And as the disease continues and progresses in a group of people, it leads to a state of cognitive impairment called mild cognitive impairment. And in a group of those with mild cognitive impairment, they go on to develop dementia later on. So not everybody with Alzheimer's disease will go on to develop dementia.
Okay. Now, so it sounds like there's many different things that can cause dementia. Alzheimer's disease is the most common cause of dementia. Is that
True.
correct?
Absolutely.
Now, how is Alzheimer's disease different than from other potential causes of dementia?
That's
What
a
else
good
might
question.
cause it?
Sure. I mean, when we talk about dementia, again, as I said, I mean, it's a generic term to denote abnormal cognition, and other conditions besides Alzheimer's disease that can lead to that state of abnormal cognition are numerous, basically. It kind of depends on age of presentation when we think about what we call differential diagnosis or what the underlying problem might be. In somebody who is a bit older, of dementia with Lewy bodies, for instance, again, happening in people who are towards the elderly side. There are other kinds of dementia that affect people at younger ages, such as frontotemporal dementia, for instance, and it comes in different subtypes. Certain general health problems, if they go on for long enough, can affect cognition. Sometimes infections, for instance, can lead to dementia. So the causes of dementia are numerous, and that's part of the responsibility of us as doctors to decide in each given patient what is the cause of their underlying dementia.
Okay. Now, I know one of the areas that you specialize in is frontotemporal dementia. How might somebody present differently with symptoms of frontotemporal dementia versus Alzheimer's disease?
That's a great question. So the presentation of different kinds of diseases that lead to dementia is dictated by part of the brain that is affected. Frontotemporal dementia is a kind of dementia that, as the name implies, affects the frontal and temporal lobes of the brain, which are at the front of the brain. Frontal lobe is extremely important for our behavior, how we conduct ourselves in regards to the society and others. So in that sense, a common presentation of frontotemporal dementia will be abnormal behavior. The other common presentation of frontotemporal dementia due to involvement of the temporal lobe is a language problem, a particular condition called primary progressive aphasia, which is the impairment of language, which is progressive over time. So language and behavior manifestations are the main presentations of frontotemporal dementia, whereas in Alzheimer's disease, the commonest manifestation is memory problem, the forgetfulness that everybody is aware of. Although I have to say that Alzheimer's disease can also present in other ways, such as problems with visual spatial abilities, problems with executive function that we just talked about, and even sometimes problems of behavior.
Okay. Now, what happens when somebody receives a diagnosis of a degenerative brain disease like Alzheimer's? What are the recommendations and the next steps?
Absolutely. So I think it is a potentially life-changing diagnosis. So in that sense, it is a very sensitive diagnosis to give to somebody. And therefore, I mean, the first thing as clinicians or as relatives even, we have to appreciate the importance of giving the patients opportunity and time to come to terms with the diagnosis. So that would be the first step, to give them ample opportunity to ask questions and kind of come to terms, as I said, with the diagnosis. With the diagnosis comes certain implications, such as requirement for changes in certain elements in daily life. For example, something that is particularly important is driving. We always worry about patients' safety to drive, for instance, and talk about that pretty early on. There are certain things that patients might not be as able as they were before to conduct any longer, such as looking after the finances, and that those are areas that are of significant concern sometimes. Obviously, there are things that we would like to recommend to patients to slow down the progression of the disease, the so-called lifestyle modifications, such as diet and exercise, that we can talk about more if our viewers are interested. Also, although we do not have any cure as we speak for different kinds of dementia, for some kinds of dementia, including Alzheimer's disease, of course, there are symptomatic treatments that we can offer to our patients. Obviously, we have to educate our patients in terms of what to expect from those symptomatic treatments, but there are symptomatic treatments on offer. Also, we always like to do research on these conditions. So in patients who are interested in participation in our research, from kind of descriptive studies to clinical trials, we always discuss that option with our patients. So there are a multitude of aspects to receiving the diagnosis of dementia that we try to cover, perhaps not in only one clinical encounter, but multiple clinical encounters as we see our patients with these conditions.
Okay, and might the recommendations or medications that a person is prescribed be different based on the different diagnosis of the cause of dementia?
Sure. I mean, some of the recommendations are generic, such as importance of exercise and diet. That applies to everybody who receives diagnosis of dementia. But certain other recommendations, such as appropriateness of symptomatic treatment, is going to be different based on the kind of problems that patients have been diagnosed with. Also, in terms of requirement for sort of modification in life, the requirements are different in somebody with memory problem compared to somebody with visual spatial problem, compared to somebody with language or behavioral issues. So in that sense, the recommendations are going to be different and tailor-made based on the particular presentation.
Okay. It looks like we've had a few new viewers join us. So just a reminder that as questions come up, you can go ahead and type them in the comments box, and Dr. Sajjadi will be happy to answer them. It looks like we do have one question right here. Dr. Sajjadi, is there a certain age when older adults should be evaluated for dementia or mild cognitive impairment? And but is there an age at which it's recommended that people go and maybe get annual checks on their memory and cognition?
That's a great question. I don't think we can recommend something like a cognitive screening as something similar to, for example, breast examination screening or colonoscopy screening or things like that. And the reason for that is that although I mentioned that conditions such as Alzheimer's disease have a prolonged preclinical phase in which the abnormal proteins are accumulating and the patient is not symptomatic yet. But since we do not have any disease-modifying therapies on offer, the purpose of that kind of screening assessment will be defeated by the absence of kind of disease-modifying therapies. I would say instead of kind of having a certain age threshold for recommending cognitive screening, what would be important would be to have a low threshold for recognizing the symptoms of cognitive impairment in our loved ones and or in ourselves. And then, I mean, seek help and support if we are concerned enough about these problems being unexpected or abnormal compared to others who we know and are interacting with.
Okay, well, you know, kind of going off of this question, and I want to go back to the of driving. You know, a lot of people will ask, why should I get a diagnosis? Or, you know, I don't necessarily want to see somebody about my memory problems because I'm worried about losing my license or things like that. What are the benefits of early diagnosis, and what might you say to somebody who has concerns about that?
Yeah, I mean, I think that's a very good question, and that's a question we encounter commonly. I mean, I think we have a kind of atmosphere of nihilism when it comes to diagnosis of cognitive problems, but I don't think it is kind of justified. The reason for that is that although we do not have, I mean, chemicals or medications on offer that are disease modifying, accumulating evidence from all the research efforts that are going on suggests that there are lots of things that we can do to improve our cognition. And once or if a cognitive impairment has started to slow down its progression. So in that sense, I think the reinforcement of those ideas will be a very important element here. So importance of exercise, importance of diet. Everybody knows about these things being good, but I mean, in terms of specifics of it, like how many minutes of exercise per day, or what kind of food to avoid, or what kind of diet to follow, those are all things that come from a detection of these conditions. Also, in terms of things that we should avoid, or the modifications, as we discussed, that require to be made, these are things that can only be adjusted or recommended when we see a health expert. The other thing to say, for some of these cognitive disorders, actually they go on to evolve over time. So a good example of that would be something like primary progressive aphasia that I just mentioned, for instance. So these problems sometimes start with a apparent cognitive issue, but patients go on to develop motor complications. They start having problems with the gait and balance and things like that. So to have a clear vision in terms of what is to be important consideration here.
Okay. Looks like we have another question here. The question is, how do you reconcile the need for socialization and the fact that going out can sometimes be overstimulating and result in meltdown?
Well, excellent. That's a good question. And that's something that we, again, encounter a lot. I think the first step in kind of coming to terms with the diagnosis of dementia and kind of being ready to embark upon the journey is to accept the diagnosis. I think part of the problem that comes from, or part of the stresses that arise from these social encounters are due to the stigma that comes with a diagnosis of dementia. And I think that is something that us as clinicians and as a society actually have a big responsibility to overcome, in the sense that dementia is just a disease. It's just a brain disease, like an orthopedic issue or a cancer diagnosis. Not that they are similar, but in terms of the fact that there are actually physical problems coming from structural problems arising from a brain disease. So once we are open to that diagnosis and we are open to the problems that come from it, social encounters become much easier. It is true that in somebody with memory problems, seeing too many but if you think about the risks and the benefits or the disadvantages and advantages of going out and actually being active in society, I think the advantages are overwhelmingly positive, and we should kind of encourage that.
We just have a few more minutes. So Dr. Sajjadi, I just wanted to ask about, what are the current research projects that you're working on, and what's the best way that people could get involved in this type of
Absolutely,
research?
that's a great question. Well, I mean, in UCI, University of California, Irvine, we are very active in different areas of research into causes and potential treatments for different kinds of dementia. And basically, in terms of my own research interests, I'm interested in a number of these conditions. I'm interested in kinds of dementia that affect people at young age, the so-called frontotemporal dementias that we discussed, and we are doing active research on the natural course and the evolution of symptoms and how we can go about early diagnosis of these conditions. We are also, in our Alzheimer's Disease Research Center, very active in seeing patients and researching patients with Alzheimer's disease and also other kinds of dementia. And also we are active in clinical trials, and we always enroll patients into treatments that have gone through rigorous ethical review and have been deemed appropriate. And also another area, active area of research in University of California, Irvine, which is kind of specific to us here, is our research in dementia and its risk factors in the oldest old population, who happen to be the fastest growing segment of our population, people who are aged 90 years and older. They have been neglected by and large in different clinical trials and from many different research studies just by virtue of their age, but we are increasingly aware of their importance in terms of their demographics, as well as the differences in the types of dementia that, or the types of conditions that lead to dementia in these individuals, and studying the oldest old is an active area of research of mine.
Okay, well, thank you. And the best way for people to learn about these various research studies that are happening is the UCI Consent to Contact Registry, or the C2C registry. So if you want to learn more about research projects like this that Dr. Sajjadi and his colleagues are conducting here at UCI, you can visit that website and enroll in the registry at c2c.uci.edu. And Dr. Sajjadi, I just want to thank you so much for your time. This was very insightful. Thank you for answering questions from the community. And I do also want to just let everybody know about an upcoming education program that we have on Tuesday, next Tuesday in the evening, March 5th. It's going to be a distinguished lecture, UCI Mind's annual distinguished lecture on the brain at the Irvine Barkley Theater. The event is sold out, but we're actually going to be live streaming it here, right here on Facebook Live. So you can tune in at 7:30 p.m. Next Tuesday evening, and Kirsten's going to type the information here in the comments box. Dr. Ronald Peterson, director of the Mayo Clinic Alzheimer's Disease Research Center, will be delivering that lecture. Dr. Sajjadi, thank you again.
Thank you for listening.
We hope that you will join us next month, April 5th, again at 9:00 a.m. Pacific Standard Time. I'll be joined by Dr. Andrea Tenner, who will talk about whether Alzheimer's disease is an immune disorder. Thanks very much, and we'll see you next time. Bye.